For joining us for this month's webinar with Dr. Richard Barron and Daniel Wolfson, who will be discussing the intersection of choosing wisely and trust. Before we begin, let me cover a few logistics. This meeting will be recorded and shared. While our presenters are speaking, we will have the lines muted to reduce unnecessary noise. We will unmute at the end of the presentation for questions and comments. Please feel free to enter questions into the chat box throughout the presentation. Now I will turn it over to Kelly Rand.
Thanks, Kate. And thank you, everybody, for joining us today. I'm excited for us to have a conversation on the intersection of trust and choosing wisely. I have with me today Dr. Richard Barron, who is a board-certified internal medicine and geriatric physician, and is also the president and chief executive officer of the American Board of Internal Medicine and the ABIM Foundation. Also joining us today is Daniel Wolfson, who is the Executive Vice President and COO of the ABIM Foundation. And both Dr. Barron and Mr. Wolfson were instrumental in leading the Choosing Wisely campaign and have led the Foundation's evolution on the trust agenda. But before I get into my conversation with them, we wanted to give everyone just a little bit of context on Choosing Wisely and the new Trust Initiative. So Kate, if you could share the slides. We wanted to share a little bit of what Choosing Wisely has done. We think the campaign has had quite a reach with 88 societies, more recommendations every day. A lot of consumer organization partners are very patient-friendly materials. Over 600 of you in our learning network, and over 7,000 people on our newsletter subscriber list. Kate, next slide. And some of the things that we were happy that happened and we think are notable achievements are Choosing Wisely has spread over 20 countries and is in places like India and South Africa. It's also inspired the Choosing Wisely STARS program, which is student-led initiatives in medical education across the country. More than 1,000 articles have been published in peer-reviewed journals, and 135 of them have focused on actually changing Choosing Wisely and overuse practices in hospitals and health systems across the country. Choosing Wisely was specifically mentioned in CMS's Transforming Clinical Practice initiative, and the foundation got to work closely with many organizations to help them implement Choosing Wisely. And we've also gotten to work with statewide initiatives such as Delaware with Dr. Rob Dressler, who is one of our participants today, with the Virginia Smarter Care Alliance, and with the Robert Wood Johnson Value Champions program, which focuses on safety net settings, and the American Hospital Association's High Value Care Alliance. And now I'm going to turn it over to Daniel to talk a little bit about the new Trust Initiative. Daniel?
Well, before I do that, I wanted to recognize that Wendy Levinson is on the phone, and she's been leading the effort on the 20 countries that have adopted Choosing Wisely. And she's also the originator of STARS. We imported STARS into the United States through Canada. And we've been, the foundation has been supporting that effort. So, and then I also want to recognize Kelly Rand for all the incredible work she's done over these years, and much appreciated. I know people on this phone call know and love Kelly and recognize what she's brought to the table. And the success of Choosing Wisely, I think, rests largely on Kelly's shoulders. So thank you, Kelly, for all your work. Rich, did you want to say something too?
I wanted to really applaud Kelly's efforts in knitting us into a network of learners and creating an ongoing conversation, keeping the conversation going, and very, very grateful for the scope and energy that Kelly has brought to all of the ways that Choosing Wisely has walked and talked and moved around the country and around the world. Thank you, Kelly.
Thank you.
So let me introduce the Building Trust Initiative, trying to elevate the importance of trust and make it a central feature, a central operational principle in improving healthcare, much like what we did with Choosing Wisely. making overuse an important issue that we wanted to address, we really want to do the same in building trust. And we'll go through some of the reasons and parallels between building trust and choosing wisely later on. But like choosing wisely, we want to build a community of organizations interested in addressing trust as a means to achieve better healthcare. And we're working with many organizations, that is specialty societies, but a much more expansive list of health plans, of hospitals, certifying boards, academic institutions, and consumer and patient organizations as well. So that gives you a little context. We're collecting trust practices, that is means and actions that actually build trust from the public and between organizations, between health plans and hospitals, and all those interactions that go on in the healthcare arena.
Thanks, Daniel. And I do want to encourage you. I'm gonna start the conversation by asking both Daniel and Dr. Barron a few questions, but I would love to hear your questions as well. So I want to encourage you to really put things into the chat, and we will open up for questions from the audience at the end. But to start off the conversation, to my understanding, there were 4 areas which influenced the Foundation's focus on trust: ABIM's trust experience, the growing recognition of misinformation, the connections made to trust, health equity, and choosing wisely, and the general erosion of public's trust in healthcare. So I thought perhaps we could start off, Dr. Barron, with you telling us a little bit about ABIM's experience and how that experience influenced the Foundation's trust mission.
Thanks, Kelly. And that is a great place for us to start, because it was the first set of steps on this journey. I think all of you know that ABIM's experience over the last several years has really been pretty turbulent. And it started shortly after I stepped into the role as CEO, maybe somewhat before, that there got to be, and anybody connected with healthcare has been aware of this, really a lot of terrible things said about ABIM, and a very negative backlash in the broad community of doctors that ABIM certified. And when we tried to figure out what was going on, we were struck by a lot of what people were saying were simply not true. That people were putting information out there that was completely inaccurate. In fact, it was on its face preposterous. We had a journalist attacking us saying, we in 1 week that we were on the verge of financial collapse, and had some Ponzi scheme bookkeeping system, followed a week later by we were rolling in so much money that we were buying a luxury condo. And it's like, wait, we're talking about doctors who are educated people who care about truth, and these things were being said that on their face are inconsistent with each other, and yet they were widely influential in the way people were feeling about ABIM, and ABIM sustained an enormous amount of reputational damage. And we had to try to figure out what's going on and how should we respond to it. And the first level response was, well, that stuff's just not true, so we'll go out and tell everybody it's not true, that what you're saying is not accurate, our accounting is fine, we have independent audits, whatever real estate we bought, we use for business purposes, whatever. And it made no difference at all. And it was really surprising, because we thought if we stood up and just put the facts out there and the truth out there, that would change people's minds, and it didn't. And we started to think about what's going on here, what's happening. And around the same time, we started to see political changes in the national discourse. And we started to see various people in roles of leadership straight out saying things that were not true. And it was, what's going on here? What is it that's causing people to move away from facts and lose trust, or excuse me, move away from facts, and why aren't facts more persuasive? And we concluded that it was all about the relationship that we had with the diplomates and the way in which we had lost their trust. We were distant, we were arrogant, we were disconnected, we were focused on the work that we did and the product we created. We were not focused on their lives. And that in that environment, we realized that people were willing to move away from us, distrust us, get out of relationship with us, and then not believe anything we said. And as we started to think about who else in the healthcare universe might be in a situation where they were disconnected from a constituency that they were trying to serve, we realized that hospitals and health systems and physicians and the healthcare system writ large were relying on the same kind of things that we were relying on at ABIM. It's like, well, we've got the New England Journal, we've got evidence-based medicine. We're going to tell them, they're going to come to us when they really need us because we have facts and the truth. And we started to realize that something had really changed in the world, and that facts and the truth were not as compelling as they had been, and that trust was much more important as a core ingredient. And at ABIM, we spent really several years focusing on a strategy of rebuilding trust with diplomates, which was all about relationship and engagement and everything about the way our voicemail worked to the tone of our letters. It wasn't so much about program design, it was about rethinking relationship. There were plenty of changes in program design. And I don't think at the time we started doing it, we realized that it was all about rebuilding trust. But ultimately, we came to realize that for ABIM to survive and thrive, we were going to need to rebuild trust. And we thought that the lesson that ABIM had learned might be an important lesson for the rest of the healthcare system, focus on the way in which professionals need to be thinking about trust building, trust creation as an intentional strategy. And that was how the foundation decided to move into that aspect of what was something that people really weren't thinking as much about, and we thought they should be, in the same way that when we started with Choosing Wisely, most people in healthcare weren't thinking that much about waste. It's hard to imagine at this time, weren't thinking that much about unnecessary care, weren't thinking that much about value-based care. When we started talking about it, all of a sudden, or as we were talking about it, Choosing Wisely became a tool in an important toolbox as people were trying to deal with the challenge of waste, trying to deal with the challenge of unnecessary care, trying to survive and thrive in value-based environments. Now Choosing Wisely was a solution to a problem people had. And we thought, people are going to have a problem with trust, even if they don't realize it now. We want to set about trying to build toolkits, exemplars, just as we did in Choosing Wisely, focusing on trust.
That's a great answer and a great transition to my next question, which is for you, Daniel. How do you think this erosion of trust has impacted healthcare? And can you touch upon how that how low value care may play into that erosion?
So, Choosing Wisely, I think, was powerful because of its focus on the patient-physician conversation. And without trust of that patient-physician relationship, there cannot be really good conversations about low-value care, because at the time when you're having conversations about low-value care, there's a certain amount of vulnerability that that patient feels at that moment. And if there's not trust, having conversations about what not to do don't go so well. But trust has gone down in many sectors in our society, not just healthcare. But when we began to look at what was happening in trust in healthcare, we found that the trust levels were high, but in the last 25 years, it was the biggest loser by losing 50% of the percentages of trust. So we thought that was alarming. We thought that a lot of institutions were under attack in healthcare, and we thought that being intentional about it was going to be important. We also felt that professionalism, which has really been our our mission, using that as a leverage for improving quality of care, was all about respectful and trusting relationships. And it was easy for us to kind of turn the frame of professionalism on trusting relationships. And when we looked at trusting relationships, we wanted to think about how are different people in different sectors, socioeconomic, racial, and ethnic, were looking at these kind of conversations. Were they thinking that there was trust enough in the relationship to have these kind of difficult conversations? And and I see that Denise Smith is with us today. With the aid of Denise Smith and her organization in Connecticut, we did focus groups with low-income individuals and a mix of people, including people of diverse ethnic and racial backgrounds. And we found, not unsurprisingly, that there was a measure of trust there, particularly in tests, but large mistrust when it came to what are you going to do about it? What are you going to treat? What procedures are you going to perform? And we realized again the importance of the conversation, the importance of the alignment of values between the patient and physician, and the importance of trust in those kind of conversations. So I'll stop there.
Great, thank you. So Dr. Barron, we've also seen a rise in misinformation in recent years. How does that impact healthcare? And in particular, how can that impact the physician-patient conversation?
Well, this is one of the major factors, I think, driving erosion of trust and driving confusion on multiple levels. The RAND Corporation has described 4 components of what they call truth decay. One is the increasing blurring between facts and opinion. You can see that in the newspaper every day, even in reputable top-line newspapers. The news stories are right there next to the opinion stories. You can't really tell them apart. Another is the rise of sources of information. When people are drowning in information, it's harder and harder to evaluate the reliability of what you get. A third is a decrease in the authority of people who used to be trusted. And I think this one is most important in healthcare, that we are finding that that what we used to see as credible authorities, and then finally a disagreement about facts, about basic facts, what you're going to call a basic fact. And I think that we are seeing a very broad assault on expertise, often masquerading as liberty, as freedom. That I should get to believe what I want, I should get to choose what I want. There's that famous Daniel Patrick Moynihan quote, you can choose your beliefs, but you can't choose your facts. I think that is increasingly up for grabs in important ways. Tara Montgomery, who's also on this call, just is doing her master's thesis on trust and what builds it, what takes it away. And I think that the idea that we're now in a situation where facts themselves are up for grabs. Is COVID a hoax? We got 300,000 dead people, but we have almost half the country voting for somebody who says COVID is a hoax. So that tells us something important about the world. Whatever our political views may be, there is plenty of evidence that lots of people in the country are not accepting basic facts as facts. And that's an environment in which misinformation breeds and spreads. And you add to that social media and the way in which people are getting information, and they're getting information from people with whom they are in relationship, but it might be crazy Uncle Billy. So crazy Uncle Billy says this COVID vaccine, you can't trust it, it's contaminated with whatever. And somebody's going to believe that in a way that they might not believe CDC because of feelings that they have about government generally or the federal government in particular. So all of these ways that we have feelings about institutions and feelings about the world are increasingly bleeding over into what we accept and don't accept as facts. And in an important way, I think people were really struggling to get our arms around what facts are. And that's an environment in which misinformation just moves around really quickly.
And before we move away from that, there's a great question from the chat that asks, what are some major sociocultural factors that you think affect the patient-physician trust relationship?
One of the concepts we're talking a fair amount about as we talk about, and that is a terrific question, as we talk about some of the disparities and inequities that COVID has revealed, we talk about the concept of earned mistrust. You know, I think many of us are familiar with historical examples of inequity. Tuskegee is on the tip of everybody's tongue, and everybody can cite that. And of course, Tuskegee was a long time ago. And so there may be people who want to say, yeah, but that was then and this is now. And Tuskegee was exposed and it was horrible. And we took care of that. You can say that if you want, but then if you are a member of a Black or brown community and you look at the COVID data, you see real-time confirmation that you are not being well served by the US healthcare system. It is your daily experience. And if we talk to colleagues, both clinical colleagues who have experience of being disrespected and distrusted based on their race, based on their gender, the kinds of stories that you see about a doctor on an airplane responding to a call, but if it's a female physician, well, you can't be a doctor. If it's a Black physician, you can't be a doctor. So the way in which lack of trust and the way in which earned mistrust is a continuing factor. At this point, you have entire communities saying, you have to show me that you actually care about me. You have to earn my trust. You have to demonstrate some understanding of my situation. And I think that the healthcare system is in varying degrees of readiness for that. I mean, Daniel, as you talk about folks in healthcare delivery systems and health equity, how much do you think people are identifying affirmatively a need to build trust as a core strategy for achieving health equity?
Well, I think, when you look at the processes and outcomes of care, it's dramatic differentials in cardiac care and asthma care. And the mistreatment continues and gets reinforced over time. How are people, I think, addressing the disparities? Well, a strategy that is always the best is building up a pipeline of clinicians where you look like me, and we know that when that happens, healthcare is much better for the African American community and Latino X. That's one strategy, but this is going to be a long road of awareness of the biases that people have built in, and the need for reflection and education and awareness, and then to think about some of the systematic racism that's built into the system that needs to be addressed for us to get rid of the disparities and inequities in the system. Where we locate our hospitals, where we locate our clinics, are all a part of that disparities. How we, the social determinants of health, where we place grocery stores and build better nutrition, better exercises, facilities in neighborhoods of high need. So a really complex question.
And to continue on that, we also have another question from the chat, and we've talked quite a bit about health equity from a race and ethnicity standpoint, but this question asks, how did generational perspectives impact the erosion of trust, which we haven't spoken about.
Well, certainly we can see if you go to a really older generation, a World War II type generation, the greatest generation that accepted at face value things that scientists said and things that government said. The American Board of Internal Medicine was created in 1936. They basically put the 9 smartest internists in the room and they made rules for everybody else. And that was kind of the same model that doctors had with respect to patients. We will speak, you will listen, we will command, you will obey. And that clearly over time became less and less salient for any numbers of groups of people. So, the cohort that went through the Vietnam War era and came to distrust things that government might say. And I think that in the last 4 years have just been a carnival of distrust. That's the wrong word, but what do we have going on right now? We have the president of the United States disputing the results of an election. And on day one of his office, I read a book by Masha Gessen and about autocracy, and she points out that literally the first thing the administration did when they sent, remember Sean Spicer, the press secretary, into the press room, on the first day of the administration, he said it was the largest inaugural crowds in history. Well, not only was there photographic evidence that that wasn't true, there was evidence from ridership on the regional transit authority in Washington. There were 5 different ways that wasn't true. But now we're living in a world where the press secretary for the president stands up in front of the world and says something absolutely verifiably not true. I think things like that deeply, deeply shake people's trust in a generational way. If you grow up in that, you might not be outraged by that. You might say, oh, well, that's just how the world is. We can't expect political leadership to do anything different. So I think the generational piece has a lot to do with kind of where you come of age and what the norms are at the time and how you acculturate to what you can expect and rely on. And my goodness, as we now finally have a vaccine and hope to begin distributing it, hearing that substantial portions of the population don't believe it, and don't trust it and don't think it's safe and don't trust the process that produced it. I think we've always had some degree of vaccine skepticism, but it hasn't been 40% of a population that wasn't going to accept a vaccine.
I think with the information flow coming to patients, the whole dynamic of the patient-physician relationship has leveled, and better for conversations to go on in a shared decision-making or informed decision-making about what's right for a patient. So it made it right for Choosing Wisely to come on the scene, where the symmetry of information could be better, and it was our role to provide information to both the patient and the physician in that relationship.
And
Bill Adams got a good question.
Yeah, so Bill Adams just said to trust someone is to believe that they will act out of goodwill with my best interest in mind. Overuse, misuse, payment issues all contribute to the erosion of trust in healthcare by lots of patients. And I thought that led into one of my questions for you, Daniel, which was, we've talked a little bit about, financial toxicity, and you talked a little bit about what we heard from the focus groups, but are there any other things that we've learned from Choosing Wisely that you think helped us evolve to this focus on trust?
It's a great question, and thanks, Bill, for that question. I really think it was this notion of dual agency. Dual agency is when a patient feels like the physician is not treating them with a primacy of the patient, with the interest of the patient above all economic interests. And what I think that Choosing Wisely did, it gave the ability for patients and physicians to have that relationship without the noise of payment in the background. I'm here for us to decide what's in your best interest, what's in your preference. So I think that alignment of values of the patient and the physician around what is the right kind of care at the right time for the right person was kind of the key to, I think, building trust within the Choosing Wisely campaign, because all of a sudden we had people armed with information on both sides. And, we were very intentional about, let this be a conversation just between patients and physicians, and let's reduce some of the noise around that. So there could be a conversation that was clearly in the interest of the patient without the influence of, maybe it's about cost, maybe it's about something else behind me, and not between you and me, the doctor and the patient. And I think that was a real breakthrough of Choosing Wisely that built the trust of aligning the values of the patient and the physician.
I think, Daniel, if I could add, the converse in Bill Adams' question is that a variety of behaviors that were routine behaviors within the healthcare system are things that deeply have undermined trust. That when you think about, wait a minute, Elizabeth Rosenthal's book, Pay Till It Hurts, where the origin story of that book, she describes, she comes back from China where she's been with the New York Times for 10 years in this whatever health system it is, and she's just had her 50th birthday. And now she's in Manhattan and her doctor says, you need a colonoscopy. And she calls 3 different places, and the prices for the colonoscopy range from $1,500 to $15,000 across 3 places in Manhattan. And Elizabeth Rosenthal says, how could that be? Like, how could that be? And people who do health policy say, well, that's because the physicians set independent prices and that there's insurance and you don't understand how networks work. But at some point, that kind of behavior as routine behavior deeply undermines trust. And whether it's variation in prices that nobody can explain, whether it's outrageous prices that nobody can defend, whether it's unnecessary care that may have injured somebody, these are things that really do undermine trust. And so one of the reasons that we're doing this whole conversation with the Choosing Wisely faithful and the folks who've been carrying Choosing Wisely forward is, in a very deep way, we think that Choosing Wisely, without even realizing it, was a lot focused on taking steps that would build trust, taking steps that would support a more trustworthy relationship, as Daniel was describing. And so we think there's kind of a natural kinship between Choosing Wisely and the work that the foundation is now doing on trust.
And as we matured, we began to think about financial harm, and besides physical harm, financial harm and psychological harm of unnecessary care, and how that financial harm hurt the trust in the healthcare system. Surprise billing, for instance, is being a real trust destroyer of the healthcare system.
And we have another question in the chat. Do you feel that the initial intention has been manipulated in such a way to erode trust by being used in payer incentive payment programs?
The initial intention of Choosing Wisely, I'll let Daniel respond to
that.
Well,
we were very careful to keep dollars and payment aside. And our philosophy was, health plans do what they do. Our organization is going to be focused on making care better and not advocating that these become a part of incentive systems, and that we would get a lot more mileage if we were using professionalism as our lever, which is our mission, rather than being incremental, small incremental advantages in payment. We were much more interested in having a cultural change across all kinds of interactions between patients and physicians, not just the 600 recommendations, but it would be a cultural change where physicians were asking themselves, why didn't I do a test, to why did I do a test? And that cultural shift and cultural mind shift is what we were after. So we really tried to stay away initially and ultimately away from payment incentives. Not that we don't recognize that fee-for-service does accentuate and increase volume. We're not naive to think that that doesn't happen, but that was not going to be where we focus. We wanted to focus on a better quality system and taking away things that we could put into social determinants of health, or things that we would have the system much more beneficial. But cost was not in our lexicon. It was improving quality, improving safety, and doing no harm. So those things I think of doing no harm relate to our trust agenda, where we want to make sure that trust is not being lost and we're not doing any harm to patients. Examples would be surprise billing. Are we doing harm to people when they get a bill? And what does that do for trust? As we begin to think about how we apply trust to solve problems. And that's, I think, ultimately what we want to do. How can trust be a mechanism to solve problems in the healthcare system?
And there are more questions in the chat, but I have one last question that I did want to make sure that both of you answered, as I see that we're at 4:40, is that, choosing wisely developed at a time where overuse was not an easy topic, much like trust is not an easy topic now, when, people were talking about death panels and rationing of healthcare. And so the campaign took an approach that was very much about transparency and collaboration. What things have you learned about how the Choosing Wisely campaign was built that you plan to apply to the new trust initiative?
I can take that.
Go ahead, Daniel. I was going to say you go first.
Okay. Well, one thing that we learned from Choosing Wisely that we're now applying to the Building Trust initiative in particular is the importance of partnerships. And that to us, our 80 so or more relationships with specialty societies was really important. And the thing that I think that made that go so well is the trust in their competency, trust in the competency of the specialty societies to come up with recommendations about what not to do. And we're doing the same thing in the Building Trust initiative of thinking about, let's ask organizations what they do to build trust. And we're asking consumers, as we did with Tara Montgomery at Consumer Reports. We have looked at what can the patients, what do they need to know? What can patients tell us about building trust, and to listen to that voice. So we're trying to listen to a lot of voices, have lots of input, but ultimately it's all about collaboration and trust in those types of collaborations and partnerships. We're a small organization. We really thrive on collaboration, convening people around a common problem and how to address it. So those are some of the things that we've learned in the Choosing Wisely campaign that I think really bring forward what we're doing now. But reliable relationships are what it's all about. And that's what we plan to develop in the Building Trust Initiative, is those relationships that are reliable, that they can trust us to be the convener, building the platforms, building the showcasing of these practices in a trustworthy way. And I think we've always been a trustworthy convener.
And I'd underscore the word practices that Daniel used. That one of the wonderful, miraculous things about Choosing Wisely was the way that it engaged people in a whole series of actions. It engaged societies in having the conversation. It engaged people in clinical service delivery, in using a set of tools. It drove a discipline of measuring impact of different kinds of things that people were trying. And so there were lots of roles for people in Choosing Wisely. And the whole idea that what we're hoping to get out of this is not some abstract theoretical conversation about the importance of trust. We're really trying to come up with something that gives people tools and a way to think about focus on rebuilding trust as a core organizational strategy for success. And we see that as having multiple dimensions between clinicians in a delivery system and the delivery system, between the delivery system and the patients, frankly, between insurance companies and patients, between insurance companies and delivery system actors. So trust is critical at every one of those phases. And we're hoping that we can come up with a campaign that involves a vanguard community of people implementing and adopting practices designed to become more trustworthy.
Well, can I take the next question about the best ways to integrate building trust in the physician practices, which is a great question. And actually, we want to hear from physician groups about how to do that. But the things that I think about are, I call them the 3 C's, and that's competency. I can really rely on you to do what you say you're going to do. The C for communication, you're listening to me, and and teams are functioning well. And the next one is caring and compassion. I really feel that you care about me above all else. I feel your compassion, your sympathy and empathy when it's necessary. But as I said, we really want to hear from other groups about how they go about building trust in things they do. When we did a challenge, it was kind of a precursor to what we're doing now. We found 2 great examples of how practices build trust. One was a practice in a federally qualified community center in Chicago, where the screen, the EMR screen, was turned around so both patients and physicians could look at it. And then an animation that educated both the patient and the physician about how to have conversations about their medical care. And it was very open and transparent. And I think it built trust that now you're trying to engage me in my care, and I can see what you're writing about me. It's very transparent. The other example through that challenge was an LGBTQ clinic, where a family physician in Des Moines, Iowa, opened up a clinic for LGBTQ population, trained people about pronouns, trained people about the healthcare of this population, and made a safe space for a population that did not feel like they were being treated well in the medical care system. So those are 2 examples of what we consider trust practices that really promote and generate trust in the healthcare system.
So there is a question in the chat, and this was I think possibly a difficult one, but is telehealth building trust or harm?
So I don't think it's building harm in any structural way. I think it's like any other tool. It can be used in a way that engenders and builds trust. It can be used in a way that undercuts it. I think that in the years that I was in practice, which was before we were reliably doing telehealth, it was hard for me to see how making an 85-year-old lady come out on an icy February day to get her blood pressure checked was doing her a favor. It just didn't seem like there must be a better way to do this. So I think as long as clinicians are using telehealth tools in ways designed to serve patients and meet their needs economically, effectively, promptly, I don't see anything particularly damaging or destructive about it. Like anything else, there are some things that it is very well suited for, and there are some other things that you can't use it for. And I think we'll all be negotiating that for a while. But if you look over history at the integration of communication technologies into medical practice, I read some article a million years ago about the introduction of the telephone in the early part of the 20th century, and all kinds of articles in JAMA about, is this good for patients? Is it bad for patients? Is it? And I think there's nothing structural about telehealth that takes it, that a priori makes it one thing or the other. I think it's more how it's used.
So we are coming to the close of our hour. So I want to ask both of you, and I will encourage, we do have a few more minutes. So if anybody has any more questions, you can either raise your hand or put them in the chat. But is there, I guess, any last things that we didn't cover that you think are important that you want the audience to know about the Trust Initiative going forward from either of you or both of you?
Well, I think the first thing I'd put out there is once trust has been lost, it takes a long time to rebuild it, years, decades to rebuild it. And I think that, for example, vaccine trust has really been shredded by a number of steps that were taken. On the one hand, I think it's magnificent that political leadership was able to marshal the resources, financial and otherwise, to develop and distribute a new vaccine in such an incredibly short period of time. And a lot of problems you have to solve to do that. But in the process of doing that, by making it look like the timing was being driven by political considerations, that various people were going to keep or lose their jobs based on whether they did or didn't do something, I think they created an environment in which people can very reasonably distrust that vaccine. And it's wonderful that we're going to have a new administration that says that they're focusing on rebuilding trust, and we'll have different kinds of leadership at CDC and HHS who may prioritize this. But just because they stand up and say, oh, all that stuff, forget that, that was the other guys, we're the new guys, you can trust us, it's not going to happen that way. It's just not going to happen that way. And so I think that all of us need a very long lens with respect to trust and what it takes to rebuild it. And we need to be, each of us, on a personal journey to discover what are the barriers between us and the people and populations we're trying to serve, and not look at it from the perspective of, wait, I don't deserve for them to mistrust me. I never did anything wrong, but to really try to understand it through the lens of the people and populations we're trying to serve, what their experience has been and what their basis for mistrust has been, because that's going to be the only way we're going to be able to address it. Daniel?
So I was going to say something along the same lines. The saliency of trust is going to continue And what we're trying to do is invite organizations to come on a journey in a safe space to learn from each other about how to build trust. I think if we don't, if we're not more intentional about it in the future, we're going to lose it. And when we lose it, it's much harder to gain. So this is an invitation to people here that are, come join us, is the bottom line. Come join us on this journey. Have your organization, write to us and say, we'd like to join this campaign. And what we ask people when they join is to identify these trust actions and practices. So other people, other organizations, other clinicians, other health plans, other hospitals can begin to learn how to build trust in a much more intentional way that we've done in the past. I think we've taken it for granted, and I think we've seen for the last 4 or 5 years that we can't take it for granted. And we need to focus on it. We need to rebuild it. And if we're going to have patients that are going to be satisfied, they're going to be having achieve good outcomes, you're going to need trust. We're all going to need trust. And I think what ultimately is my vision is that the parts of the healthcare system trust each other because there is amazing finger pointing among the components, whether it's a health plan, whether it's a hospital. And I think we need to come together as an industry because that's how patients experience us. They experience us as a whole, and that's the experience that they see. So that's our long-term hope. But my parting words are, come join us and learn with us, and we'll become better organizations, I hope, because of it.
Thank you both so much for having this conversation with me today. And thank you to everybody who showed up today and had such good questions and comments for us. Before we end, I'm going to just turn it back to Kate for a few closing remarks. Kate?
Thank you, everyone, for joining us today. Please join us on Tuesday, January 19th at 4 p.m. for a webinar with Dr. Karina Sorensen from the Duth Magos Center of Health Policy. She's going to talk about building a better healthcare system post-COVID.
Great. So we'll see you all in 2021 and wishing everyone a happier new year next year.
Thank you all for the work you do and for putting in the time this afternoon. Hope it was engaging, and feel free to reach out to us and stay in touch. Happy New Year.
Thank you all.
Thank you all.
So much.